Good morning. So here we are. A lot more people than I thought would be here. So welcome to all the people in the building, so to speak, and then all the people online. So I have no clue how this is going to work or if it's going to work. But we have a full agenda today, and of course, some people that are clocking in online to do their presentations. So welcome to the Bone Marrow and Stem Cell Transplant Spring SWOG Transplantation Committee. First up is Mrd Krishnan, who's going to give us an update on the phase 3 SWOG 1803, and she is online, I hope, on Zoom. Mrd. Are you there, Mrd?
I don't see her.
So we're waiting to hear from Mrd. Are you there, Mrd? Well, let's move on then to how do I advance the slides? Absolutely. So we're going to go through just go buzz through the first slide set. It's like next, 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 next. Great. So I'm going to give an update of A051301 or CTN 1201. This is the intergroup trial, the randomized phase 3 ibrutinib during and following autologous stem cell transplant for relapsed refractory diffuse large B-cell lymphoma, the activated B-cell subtype. This is an alliance-led trial. Next slide. So as everybody knows, this trial has been around for a while. These are patients that have developed a relapse after initial therapy or have been refractory to induction chemotherapy, DLBCL, who are ABC subtype. using a Hans algorithm. They're randomized to an auto transplant. And during the transplant prep regimen, ibrutinib 560, and then 12 cycles after engraftment or a placebo. Next slide. So the primary endpoint was progression-free survival at 2 years for the Hans-derived non-GCB subtype. Secondary, of course, are progression-free survival overall survival, CR rates. As many of you know, this trial initially started using a nanostring-defined ABC subtype of patients, and we'll be looking at those small number of patients who were nanostring positive. Next slide. So the trial opened in 2016, almost 6 years ago. The first patient was enrolled in February 2017. As many of you who participated in this trial realized, there was a lot of difficulty in getting patients actually into the trial. 254 patients over the next couple of years were registered. Only 46 were eligible and 34 were totally registered. 195 failed screening, largely because of technical issues. So the trial was suspended in August of 2018 and reopened a year later using the Hans algorithm. Since that time, 108 patients have been pre-registered, and rather than 13% of patients being accrued to the trial, the percentage is up to 53%. So that means 57 additional patients were or have been treated to date. Next slide. So the trial was initially designed in 2016 as a registrational trial for 296 patients with a two-sided alpha of 0.05 and a power of 82%. We're never going to reach that, and discussions with the company as well as Ctep have changed the statistics. They've been redesigned over the last couple months using now a one-sided alpha 0.1 power of 74%. We've reduced the number from 296 to 160. As part of this negotiation, there was an agreement to do an interim analysis after 40 randomized patients had completed 2 years of follow-up, which was March of 2022. So at this moment, or at this time, there's an analysis being undertaken to determine if this trial should go on. If no significant difference is noted, then the trial may end. On the other hand, if the DSMB feels that this is a trial that should continue, we feel it's going to take an additional 30 months to complete accrual and 24 months of follow-up for another 4+ years. We're projecting accrual of 2.5 patients per month. So this is where if I could get down on my knee and beg you guys to participate in this trial. Obviously, with the Zuma 7 FDA approval as of last week, that may certainly have an impact into accrual to the trial. We'll just have to wait and see. But stay tuned over the next couple weeks to a month or so. I hope to be able to give an update as to where the trial stands. You'll get an official notification if it's to continue or not to continue based on the Alliance analysis. So with that in mind, does anybody have any questions or comments? Let me just step away here and check the chat. And people can certainly ask questions in the chat if we need to. Certainly hoping that people online are able to hear this. Anybody in the room? Okay, next, Brian Till is going to come up. Fortunately, he's a local, so he didn't have trouble getting here today, and he's going to talk about the ECOG mantle cell trial. Brian? Next slide.
Thanks, Pat. Welcome to Seattle, everybody. Next slide, please. So, these are my disclosures, nothing relevant to this study, I don't think. Next slide, please. So this is a frontline, basically transplant or no transplant and first remission for mantle cell lymphoma. Just to give a bit of background, I think we've been through this before, but in case you haven't seen it, the initial management of mantle cell lymphoma is somewhat controversial. There was a randomized trial almost 20 years ago now that showed a PFS benefit, but not overall survival benefit after CHOP-like induction therapy for an auto transplant first remission. And that kind of set the stage for this becoming the standard of care for younger, healthier patients, especially in Europe. There was then a whole slew of subsequent trials using auto transplant and first remission. And eventually the induction got intensified to include high-dose Ara-C. And that combination of high-dose Ara-C induction followed by an auto transplant led to about a 7-year progression-free survival in most of the studies. And so that really, most mantle cell lymphoma experts, I think, would consider auto transplant first remission to be the standard of care for younger patients, but there's still this kind of lingering doubt that overall survival really has never been demonstrated, particularly in the age of newer, that would have obviously a lot more getting better at induction therapies and in particular salvage therapies with CAR T cells and things like that. Next slide, please. So this is just to show that maintenance rituximab is also considered a standard of care after auto transplant based on a French study where patients were randomized to 3 years of rituximab after an auto transplant and versus observation. And the patients who got the rituximab had both a better progression-free and overall survival. And so we've included this as part of the trial. Next slide, please. Maintenance is also a reasonable choice to give as in a non-transplant setting as well. So this is an elderly mantle cell elderly trial from Europe that had a randomization between R-CHOP and RFC. And then there was a second randomization to maintenance rituximab or not. And the patients who got maintenance rituximab, if they had R-CHOP induction, had a overall survival benefit that did not hold true for the RFC arm. And then there's been a subsequent trial with bendamustine rituximab where there was kind of a trend towards a better PFS, but not overall survival. But it's still considered to be a reasonable approach, and to kind of keep the arms somewhat balanced, we decided to include maintenance rituximab for the observation non-transplant arm as well. Next slide, please. MRD, minimal residual disease, has been shown by several groups to have prognostic value in mantle cell lymphoma patients after induction therapy. So after induction prior to transplant, or in elderly patients who don't get a transplant, MRD status after induction is clearly there's a difference between how people do if they're MRD negative or not. And so the hypothesis was that, well, if this could kind of risk stratify patients to maybe potentially spare patients an auto transplant if they are in this deep MRD negative complete remission. Next slide. So the assay that we're using is clonoSEQ by the company Adaptive, who's here in Seattle. It's a very sensitive test. It's a two-step process. It's based on the immunoglobulin rearranged DNA of the cells, and there's 2 steps. There's this identification ID test on the original biopsy material to identify sort of the clone, and then the subsequent peripheral blood test. That's the MRD test at the end of induction, and this has a sensitivity about 1 in a million to detect lymphoma. Next slide, please. So again, the mantle cell lymphoma patients in MRD negative CR have a really good prognosis, kind of at least after an auto transplant. And we know in the elderly setting that they also have good outcomes with MRD negativity. So the idea is perhaps we could still, especially now that we're getting better and better salvage therapies, spare people an auto transplant if they're in an MRD negative CR potentially. And again, there hasn't been any randomized controlled trial in CR1 in the modern era. So that's what we're testing, is whether the addition of auto improves 6-year overall survival in mantle cell lymphoma patients in that situation. And we're trying to make this as user-friendly as possible, and it kind of tries to parallel your standard practice by allowing any induction therapy in pretty much any standard auto transplant regimen. Next slide, please. So this is the schema here. Patients get any induction regimen, and then they register to step 0, which is basically lets us get the tissue to send to Adaptive to look for the clone. They can do that even before induction even starts, but up to maybe a couple of months after induction. So at any point you send the tissue to adaptive, they get restaged with a PET scan and a bone marrow biopsy. And if they have, if they have at least a partial remission, then you send off the MRD test. And if they are in an MRD negative CR, then they get randomized. And that's about 80% of the patients. So they get randomized to an auto transplant or no auto transplant. And then both arms get the 3 years of rituximab maintenance. Everybody else, so if it's an MRD, if they're MRD positive, or if they have a partial remission, or they don't have there was some technical problem with the assay where it was indeterminate for the MRD test, they stay on the study and just kind of get observed as in the standard arm of auto transplant and rituximab. Next, and they're the randomization is stratified by the MIPI-C score and whether they got intensive high dose ARC induction or not. Next slide, please. So here's the accrual update. We so far 476 patients have been assigned to the treatment arm. There's more than that in the kind of the screening process. I think they're up to 600 and some patients. So it's moving along. It's a pretty steady accrual. The target is to get 689 patients total. That was sort of the best guess to see how many would be, in the CR and MRD negative, and to get 434 eligible randomized patients. So SWOG is kind of trailing a bit there behind the other two groups, but we are accruing steadily. And I'm showing the leading sites there with Kansas kind of leading. The SWOG sites are in red there. So Kansas is kind of leading the charge for SWOG. So that and the NCAA championship for Kansas this week. Congratulations to Kansas. Things are doing great there. So next slide, please. So just a couple of updates is that the main issue is that there's a decent percent, I think it's something like 10 or 15% of the patients in the randomized to actually just 10 of the 15% of all the patients have declined their treatment, assigned a treatment arm. Most of those were people assigned to transplant who secretly didn't want to transplant and so backed out of the study at that time. So, but there have been some on the other side too who kind of wanted the transplant and were disappointed to get randomized to the other arm. So, first lesson is just when you consent them, really kind of try to drill it home that they really need to be on board with getting randomized. And if they have a strong opinion, they just shouldn't go on the study. So we made a proposal to Ctep to see if we could increase the accrual a bit to try to make up for that issue. So we're waiting to hear back from them on that. But otherwise, things are going okay. There is just a reminder, we're allowed to skip up to 4 doses of maintenance rituximab if for COVID-19 reasons, if you so choose. I'm not sure that is enough time to allow B-cell recovery, but as an editorial comment, but if you want to, you can. You just have to make up those doses at the end. You should let the white count recover, but after the last cycle of chemo before you send off the MRD test, because you need a certain number of genomes as the denominator for it to count as a negative MRD test. And you can submit. A lot of times these patients don't show up on the radar until they've finished induction and they're ready to kind of get going on transplant. So if you want to kind of streamline the process, you can send the ID test, the tumor tissue along with the blood basically at the same time, and then adaptive will just hang on to they'll just do them both simultaneously instead of having to wait for the clonality test to result. And then finally, those patients who if you do have a patient who refuses their assigned arm, they still stay on study. So they don't come off study. We still want to follow them. We still want to know what their survival is. And then we'll just sort of figure it out statistically at the end and probably do a intent to treat analysis as well as an as treated analysis. So that's the end of slides. And we'll see if happy to take any questions from here or online.
So I have one. The Europeans are doing the triangle study. Do we have any update as to when those results, because that's a transplant versus no transplant plus or minus ibrutinib?
Yeah, I have not heard anything on that, but I haven't looked actively either. But that's been kind of brewing for a number of years. It's probably going to be finished, I would think, sometime soon. But you're right. Good question.
Hey, this is questions. Any issues or problems? We all have patients that we know have a preference, and when we randomize it, we hope that they get the assigned arm. But I agree with Brian that if you have somebody that really doesn't want to, don't put them on, because it's just going to make the study take a lot longer to complete. we really don't know the answer. There's some data that MRD may not be as important long term as we think it is in the short term. So again, this is an important study, and I think the endpoint being out at 6 years, not at 2 or 3 years, is really the right way to go. We're struggling here. We all see these patients and we don't know what the right answer is. We know that the TP53 positive patients probably are not going to benefit. And of course now there are CAR T trials. The new Zuma trial is looking at patients after first relapse. So if patients get randomized to the standard arm and they progress, they can certainly go on to either a transplant and second remission, or they can go on to a CAR T on a clinical trial. So these patients are not going to suffer if they don't get transplant and first remission, if that's what they want. Other questions or comments? Okay, thanks, Brian.
Nothing online.
Let me check. Just yeah. So if patients want to delay starting Rituxan to get COVID vaccine, how would we go about doing that? Does it need monitor approval?
I don't think so. Yeah, it's built in. I think there's a new, there's at least a letter that went out. I don't know if it's actually changed in the protocol, but it's, you probably should just check with the ECOG coordinator, see the logistics of how to do that. I don't know off the top of my head. I mean, they probably just got rituximab with their induction therapy, right? So I'm not sure that the withholding of a few doses of a maintenance is going to make a huge difference there on the vaccine. But if you want to, yeah, you would just have to make those up at the end if you're delaying those initial doses.
And again, now we can give these patients the monoclonal antibody, Evusheld, and certainly the Pfizer oral antivirals are available, and we're watching these patients very carefully. So I'm a lot more confident that the disease is more important than COVID, because we have a better chance at getting the COVID under control.
Yeah, it's a good point. I would probably, prioritize the Evusheld as the best choice instead of the vaccine.
Yeah, but I think, this is Nash Loyola. There are some patients I've had a couple of patients who have declined Evusheld, but they want to get the vaccine. So including one of my patients who's like in a post-transplant, kind of at the point where they want to start rituximab, but they do not want to get Evusheld. And their question was, they want to get their COVID shots, and we're worried about getting rituximab straight right after the COVID shot, because the coordinator told me that they'd start by day 140. And so the question happened, and then now seeing your reminder, I was wondering if could I delay it a little bit then beyond day 140? And if so, how would I go about doing that?
Well, I think you're allowed to. You need to talk to or let the research nurse contact the monitor, or ultimately Tim Fensky is always available to answer questions.
Yep.
Okay, thank you.
All right, so Amrita is here, so we can go back to the first presentation and hope that will work now.
Thank you, Pat, and I apologize for being late.
Go back to the first slide. No problem, Amrita. We are all trying to there you go. We are all trying to figure this out. Okay, you're on.
Okay, thank you. So I'm going to give everyone an update on the dramatics study, otherwise known as SWOG S1803. If you remember, Dara Len versus Len maintenance post autologous stem cell transplant, with the second randomization is stopping therapy. Do we have another slide?
Yeah, next slide. Just call out the slides, Amrita.
Okay, next slide. Okay. This is also being run through the BMT CTN, so it's CTN 1706. Just to call out here, we've had some personnel changes. For those of you who don't know, Dr. Hari has left MCW, and so our new SWOG CTN co-chair was appointed by the CTN executive committee is Saurabh Chhabra. Next slide. go back. Well, so this is the schema, as I mentioned. We enroll patients either before or after transplant to be very user-friendly. And then they are randomized to either standard Len maintenance or Len plus subcutaneous daratumumab. Everyone gets maintenance on their assigned arm for 2 years. They get another MRD assessment. If you're MRD negative, you undergo a second randomization to either stopping or continuing maintenance. Reminding everyone, large trial, 950 patients, because it's powered for overall survival. Next slide. So this is the important part in terms of just given the size of this trial, and we actually want to get 1,100 patients to account for dropout, that we've actually been doing quite well. We're registering about 30 patients a month. We've had, so as of January, 743 patients randomized, and we're having patients now, we call it step 3, which is a little confusing, but that's the second MRD assessment where they get randomized stopping or continuing maintenance. So we've had now the first groups of patients started in approximately September of 21, now being on that second randomization. The other exciting news is our Canadian colleagues have now joined us and should be enrolling actually this month now that we've worked out some of the issues in terms of drug dispensing in Canada. You know, I've heard a lot of discussion the earlier talking about the COVID challenges. You know, we made some adjustments, allowing a longer time frame for induction because many centers were delaying transplant, and also allowing patients even to get off protocol maintenance with Len in case they didn't want to come back to the center yet. Next slide. So the MRD is a key part of this study. And so one of the things we've been monitoring is the feasibility of this. We use adaptive biotech for our MRD, so it's PCR based and centralized. We've had a total of 540 patients, a total of 607 MRD samples. And you can see, so we've had 50 samples that failed, what's the word? Basically, they weren't able to get any DNA, and then 48 that were polyclonal. So in total, about 100 patients where we were unable to get a sequence to follow. So if that happens, those patients are considered MRD positive. That, you know, and we've been monitoring this very closely, obviously. I can just remind people, if you remember the IFM Dana-Farber study, they had about a 20% failure rate on their MRD by PCR. So, you know, we're within the bounds of what has been expected. Next slide. So some of the things that we're going to try and address in many of our amendments, we're on Amendment 5 right now, is one of this big issue that we may be underrepresenting the number of patients who are in complete remission. Because as you know, daratumumab can cause the SPEP to remain positive because it's IgG kappa antibody. So we are going to add the Hydra shift assay, and this has been budgeted by Janssen, for patients who have IgG kappa myeloma, who are in a VGPR, meaning they have either a positive immunofixation or positive M spike, that we will do this Hydra shift assay, and it can rule out, is that IgG kappa myeloma, or is it from the DARA? The other thing that's been done is being led by Yvonne Efebra and the QOL group through SWOG is quality of life analysis. And we've had to go a couple of revisions of that, but that amendment was also submitted, Amendment 6. So that should be a sort of in turnaround now as well. And it basically several questionnaires that have been added at several time points for patients. Next slide. So a couple of discussions, and this has come up, I'd say probably in the last month, is the issue of generic lenalidomide. We've had many sites been asking about this, and if their patients, and some, it's obviously insurance driven, if there can be switched to generic lenalidomide. And we've had some discussion through SWOG about this because the protocol says Revlimid. the general feeling is that we would be okay with this. I mean, again, it is an economic insurance driven issue for some patients, and we would rather have them be on it than to have to drop out of the study. So we are going to allow this. It doesn't appear, to be honest, with our discussions with our pharmacy managers, that there's going to be such a tremendous number of patients on it, because the supply of generic lenalidomide is relatively limited, and the cost, from our understanding, is not particularly different actually than Revlimid. So that is something new in terms of this year. Next slide. I guess that's it. I'm happy to answer questions.
So thank you, Amrita. I have two questions. Number one, is there anything the sites can do to improve the MRD analysis being of sufficient amount of material so that we don't have these negatives?
So, thank you. You're right. That's a big thing they're struggling with. So we did go back to Janssen, and for those polyclonal specimens, we've then we've asked them to pay and budget that for shipping costs so that we can request more samples, because it's basically from their initial diagnostic marrow. So the problem is with many sites too, they're not even the ones, right? The transplant center is not doing the initial marrows. It's often in the community or somewhere else. And sometimes it just has to do with the DNA quality too. So that's been a hard one, but at least we can address the polyclonal ones, and we are going to allow to get more specimens for that.
Okay, and again, I think it's still critical that the first poll be sent for the MRD, correct?
Yes, so that I would say certainly in the ones that are being done at the transplant center post-transplant, especially when your tumor cell burden is so much lower, absolutely. I mean, if those centers are doing the initial diagnostic marrows, newly diagnosed myeloma starting induction, certainly, again, if they have a high index, generally those have a fair amount of myeloma in those. So it has more to do with just, I guess, the quality or preservation of those samples. But yeah, same thing. Anything they can do in regards to making that one of their earlier polls certainly would help.
And then the other question is the Hydra shift assay. You said you're going to do it in patients with VGPR. Is this something that the centers are going to have to figure out, or is it going to be done automatically? In other words, we have a patient and we've done the assessment and say, yep, you're in VGPR. Now we need to send a sample, or is it just going to be automatic?
So unfortunately, it won't be automatic. We've tried, as a way to automate and centralize that, but it isn't. We have 5 time points we're planning on doing this, and we're going to put it in the study calendar so to hopefully make it a little bit easier. And it's going to only be IgG kappa myeloma patients. And as I said, at those 5 time points. So hopefully that will also, and we'll send a separate memo to outline that when this amendment goes through, to try and make it as seamless as possible for centers.
Okay, so that's not currently active.
No, that amendment's being submitted right now.
Okay, and then we've talked several times in the past about patients who are relatively stable for long periods of time. I know some of the centers have asked me this multiple times about reducing the frequency of visits from every 4 weeks to every 8 or 12 weeks.
I actually brought that back to the problem has been from the dispensation of the DARA has really been the issue. But in terms of the Revlimid portion, I can bring it back again with our working group committee this evening. I think there's been some pushback, to be honest, in terms of just assessment, AE assessment at those time points, and a concern. But I can certainly bring that back again, because I appreciate what you're saying, that it is not particularly user-friendly for someone 3 years out to be.
I'd just like to make a comment that patients are pretty savvy these days. They've gone through induction, they've gone through transplant. Many of them are anxious and eager to go back to work, and it's the patients of the lower socioeconomic status that are looking at the protocol and saying, how many times do I need to come and how often, and they're declining it. So we're skewing the population, I think, a bit to patients that are more financially able to come once a month or can get off of work a lot easier, et cetera. And I have to say the last 3 African-American patients that I saw all declined because of this reason. So this is a diversity issue. So if you can bring that back to the subcommittee as well. So I think it's important that we make these trials as easily accessible as possible to patients of all socioeconomic statuses.
I appreciate that, absolutely, and I will certainly do my best to bring that message back to the group.
In fact, it might be worthwhile to further bolster that, to do an analysis of socioeconomic status or ethnicity of the patients that are currently enrolled, to see if it represents multiple myeloma in general. That might give additional data for you to use.
I will definitely bring that up too. Okay, thank you. I appreciate it.
Okay, thanks for joining us, and let's move on. I think the next one is the CTN SWOG and CTN trial. There we go. And this is going to be presented by Nash. This is the consolidation trial, the CD19 CAR consolidation trial for patients that are in partial remission or stable disease at day 30. And Nash Hussain is going to present. He and Brian Hess are the co-PIs.
Thank you, Dr. Stitch, and thank you to everyone. Brian and I are very excited to present our randomized phase 2 trial of consolidation therapy following CD19 CAR for the treatment of relapsed refractory large B-cell lymphomas or grade 3B follicular lymphomas. Next slide, please. Now, these are the members of our committee and as well as our student advisors who have allowed this concept to come from a initial thought that Brian and I had to like this current protocol that we're kind of working on developing right now. Next slide, please. So the agenda for like this presentation will be to go over the background for the trial, looking at our objectives, the schema, the inclusion excluding criteria, the arms, and kind of looking at the endpoints, and kind of a little bit of an update as to where we are exactly as far as getting the trial launched. Next slide, please. Now, as we've gone over on our previous presentations, and like I said, we know from looking at the literature, the real world experience involving the 3 FDA-approved CD19 CAR T-cell constructs have shown that they have overall response rates and complete remission rates range anywhere from 50 to 80% and 40 to 60% respectively. And that despite the initial success of the CAR T-cell therapy, a vast majority of patients will relapse. And those relapsing usually have minimal responses to other lymphoma therapies afterwards, and the prognosis usually is very dim. And the best outcomes seem to be outcomes for those patients who are able to achieve a CR as their best response to CD19 CAR therapy. And furthermore, current observations have highlighted that 65 to 75% of patients in a PR and 90 to 95% of patients with stable disease at day 30 after the CAR T infusion will ultimately progress, usually by day plus 120. In contrast, DLBCL patients who achieve a CR have great responses, have excellent outcomes with 60 to 80% having a durable response. And in the second line setting, I'll go into a little bit more detail at a later slide, such as Zuma 7 Transform have highlighted similar response rates. And so when we look at the overall milieu and where like the patient population is, this is a patient cohort with an unmet need that forms the basis for this proposal and trial. Next slide, please. And this is to kind of reiterate again like what's been looked at from both the pivotal trials, including Zuma 1, Juliet, Transcend, as well as the post-approval consortium reports of CD19 CARs in the real world across a couple of different large groups. And what we can see here is, with almost close to 1,000 patients having been treated and freeze, the thing that comes across is that that despite initial great responses, durability of response can vary, it's not as great as the overall initial response. Next slide, please. Next slide, please. So, yeah, so when we look at some of these pivotal trials, including Zuma 1 Transcend, and Juliet, the most striking thing that comes across all the different trials, despite the different core constructs, is that your initial response really seems to dictate the durability and overall, how your response evolves over time. Where the overall durability of response is best for patients who are able to achieve a CR as their best response initially, and this was seen across both Zuma 1, Juliet, and Transcend. Next slide, please. And so when we look, to kind of recap, when we look at CD19 CAR T first response, what we know is approximately 50% or so of patients will get into a CR, and 70% will have a durable CR, whereas 30% may progress. Then about 30% of patients will have a PR or a stable disease, with about 30% or so going into a conversion, where 80% of those might have a durable CR, but about 70% will progress, and then of course about 20% progression of disease. And so this concept of protocol is really focusing on that 30% of patients who have a partial response or stable disease. Next slide, please. And this is kind of like pivoting off of what's been reported thus far as to how patients respond when they don't have a CR and are getting other further therapies, including checkpoint inhibitors, chemotherapy, and lenalidomide for radiation. What we see is those having a response rate have varied anywhere from 18 to 46%, but the CR rate has been anywhere from 12 to 20%, with a median PFS ranging anywhere from 48 days to 88 days, and overall survival ranging anywhere from as low as 104 days to near a year. Next slide, please. And during this, and while we're looking at this as well, something that's come across as kind of an interesting marker for response has been MRD. This is some papers that have come through from the Stanford group, which looked at MRD both in DLBCL, where we've seen they look at ctDNA burden before and after can have an impact on overall survival, and then also looking at MRD positive versus negative status post-CAR T cell can also has been predictive for progression-free survival in CD19 CAR patients. And it was kind of a basis for some of the translational studies that we're planning in this protocol. Next slide, please. And then to kind of recap one more time is that, most recently, especially with the April 1st approval, when we look at the CD19 CAR T in the second line setting, what we see is that once again, the overall survival rate for the two positive studies, Zuma 7 and Transform, were in the 80%, with event-free survival of 8.3 months with Axicell and 10 months with Lysocell, with a 24-month event-free survival of 41% in Zuma 7 and 14.8 months in Transform. But once again, kind of showing that they do better, but the curves are looking very similar to what we're seeing in the third line setting. Next slide, please. And so here's what our trial schema is for this trial. The patients will initially, who have relapsed refractory large B-cell lymphoma or follicular lymphoma, will be undergoing an initial registration based on being thought to be eligible for CD19 CAR, where we estimate accrual of around 400 patients. They'll go through their CAR T cell, apheresis, lymphodepletion, CAR T infusion, and then they'll have when they have their day 30 PET CT, this will be centrally reviewed, and the response will be assessed per the Lugano criteria, determine if they have a CR, progressive disease, stable disease, or partial response. Patients who have progressive disease will kind of go off the trial to have physician-directed treatments. Those who have a complete response will continue to be followed as an observation, look at the response assessments and biomarker draws from the translational component of our protocol. And those who have a stable disease or partial response will be randomized in a 1:1:1:1 randomization test, 3 different treatment arms versus the observation arm, with the focus on the 1-year progression-free survival, which we predict is about 25% in the observation arm versus 50% in consolidation, with a plan to have 30 patients in each arm, so a total of 120 patients that will be randomized. And furthermore, for those patients who are in the observation arm, and on this arm 4 here, there will be a option for crossover at the time of progression. And the agents that will be utilized in these treatment arms will include mosunetuzumab and polatuzumab. Next slide, please. So our primary objectives, our primary endpoint is to compare the progression-free survival at 1 year in these relapsed refractory large B-cell or follicular lymphoma with grade 3 who have stable disease or partial response on first imaging following CD19 CAR, and then are randomized to either receive consolidation versus no consolidation. Secondary endpoints include looking at the overall survival in those patients who are randomized to consolidation versus not, and to look at the complete remission conversion rates at 1 year in those randomized to consolidation versus control. We'll also want to evaluate the treatment-related adverse events occurring in patients who are randomized to consolidation arms. And we'll also be looking at the overall response rate, the CR rate, PFS, and the OS of patients randomized to the observation arm who have lymphoma progression within 12 months post-CAR T infusion, and will cross over to the treatment with mosunetuzumab and polatuzumab vedotin combo. We'll also want to look at the concordance between total metabolic tumor volume and the rate of complete remission conversion to CR up to a year, 1 year in patient randomized to the consolidation arm, as well as those in the randomized control arm, and estimate the overall survival for all patient registration study. Another correlative endpoint will be to bank specimens and PET CTs for further correlative studies. Next slide, please. So, as far as look at the inclusion and exclusion criteria by each of the registration steps. At step 1 registration, key inclusion criteria include having a diagnosis of DLBCL or lymphoid 3B or primary B-cell lymphoma, who are thought to be eligible to receive eligible to receive commercial CAR T cells. This will include those that are transferred for follicular lymphoma and or marginal zone lymphoma. They're allowed to have bridging, but cannot have polatuzumab or mosunetuzumab as bridging therapy. They are permitted to receive pola or mosun in the past, but cannot have progressed within 6 months of having received either of those agents. PET CT within 60 days of, they only have a PET CT within 60 days of starting their lymphodepletion, and if they receive a bridging therapy, repeat PET CT is mandated. Some of the key exclusion criteria to keep in mind include that they cannot receive a non-commercial CAR, and they also must not be receiving a non-conforming CAR T product through such as an extended access program. They cannot have active CNS disease or CNS disease that was prior to CAR T infusion or at the time of second registration. They cannot have Richter's transformation mantle cell lymphoma. They cannot have a history of a previous CAR T infusion or any active infections. And the registration window is after the consent for the lymphodepletion and prior to the lymphodepletion chemotherapy. Next slide, please. Now for step 2 registration, this occurs after that day 30 PET and up to 60 days after the CAR T infusion. Some key inclusions are that patients must have stable disease partial response on that that approximately day 30 PET CT, which can be done anywhere from day 25 to 40 after the CAR T infusion. They must have adequate bone marrow, hepatic, renal, and cardiac function. This includes having an ANC greater equal to or greater than 1,000, platelets greater than 70 or equal or greater than 75,000 within 14 days prior to second registration, and they cannot have received pro-factor or platelet transfusions within 72 hours of that number that's being used for eligibility. They cannot have any evidence of CRs by AST, CT guidelines within 7 days prior to registration, and must not have any ICANS greater than grade 1 by AST, CT guidelines within 7 days of registration, and no uncontrolled systemic fungal bacterial viral infection within 14 days prior to second registration. And the stratification here will be stable disease versus partial response on the day 30 PET, as well as CAR T in the second line versus third line setting, and or beyond. Next slide, please. Now, in step 3 registration, this is for that crossover arm from those patients randomized to the initial observation arm. And this is, this is for participants who have a lymphoma progression within 12 months of their initial CAR T infusion and were randomized to the control arm. But they must have imaging that clearly demonstrate that progression of disease compared to their day 30 PET. Scans are only performed as a standard of care between scheduled response to some assessments of symptoms of concerted progression will be allowed to be utilized, and they must still have the meet the clinical laboratory criteria that as utilized in the step 2 randomization, and they must be registered to the crossover arm within 28 days of having documented progression of disease. And they cannot receive any lymphoma-directed therapy after progression prior to the step 3 registration. Next slide, please. And so looking at a little bit more at the treatment arms, and looking at mosunetuzumab and polatuzumab, why we decided these are some compelling agents to utilize. Mosunetuzumab has been shown to have a CR, a overall response rate of 37% with a 20% rate in non-Hodgkin lymphoma, including in 30 patients with prior CAR T cell, where there is a 39% overall response rate with a 22% CR rate. furthermore, 70% of CR patients had ongoing response at 16 months. They had about a 29% CRS rate with 1% grade 3 or worse. That was pretty much consistent even in the prior patient who had prior CAR T with a 27% CRS rate with a 3% grade 3 or higher. And with the depressive ICANS, only 1% of patients had ICANS with 0 grade 3. And for the CAR T group, 0% of patients had any ICANS. With polatuzumab, the overall response rate has been reported at 54% with a CR rate of 21%. And this was when it was given in combination with rituximab. And the Mosin plus Pola combo in a group of non-Hodgkin patients, 41 patients, had an overall response rate of 66% with a CR rate of 49%. And in this group, like 11 patients had prior CAR T cell therapy, and they had an overall response rate of 64% with a CR rate of 47%. And then when looking at CRS, there's an 18% rate of CRS with 0 grade 3 or worse, grade 1 in 10 patients, and grade 2 in 1 patient. Next slide, please. And then, sorry for the busy slide, but this is kind of laying out kind of like the approach to the like the treatments for each of the different arms. Arm one is a mosunetuzumab arm, and as you can see here, this is kind of a ramp up dosing into cycle 1 to cycle 2, and then kind of more of a standard dose at cycle 3 and through cycle 8. When you look at arm 2, this is looking at the standard polatuzumab dosing, which would be at 1.8 mg per kilogram, sort of cycles 1 through 6, with each cycle being 21 days, as compared to the mosunetuzumab arm, which once again cycles 21 days. Arm 3 is looking at the combination of polatuzumab plus mosunetuzumab. The polatuzumab will be at a standard dose of 1.8 mg per kilogram, cycles 1 through 6. The mosunetuzumab with the kind of the ramp up dosing, once again, cycle 1 going through cycle 2, with a more set dosing, cycle 3 through 8, with each cycle being 21 days. And of course, arm 4 will be the observation arm. With the caveat that if they do have progression of disease within that 12 months post CAR T, they have the option of crossing over to the mosunetuzumab polatuzumab combo arm. And each of the arms will be supported by this robust world of studies of analysis that will allow for multiple blood, looking at multiple blood biomarker assays to be collected at different points over the course of their treatments. Next slide, please. So what are the endpoints and goals? The study needs to be completed within the cooperative group setting with SWOG, Alliance, ECOG, BMT, CTN. As we've highlighted before, this is chosen as one of 2 proposals for the BMT, CTN Lymphoma Study Design Symposium to be presented at the BMT, CTN Overall Study Design Symposium meeting in March of last year. It was ranked number 4 overall in the number 1 lymphoma proposal. We had a Ctep submission a couple of weeks ago on March the 18th of this year, and anticipate study activation in the July to August setting. And one of the big things we want to show is that if consolidated therapy is safe and effective compared to control, this may lay the groundwork for a phase 3 study with, hopefully performing it in conjunction with Mrd Capsid adaptive based trial. And if consolidated therapy does not appear to be safe or effective, we hope to gain more of an understanding regarding the MRD status with using CAPS-seq in this setting in terms of predictive value of durable response relapse, regardless of the day 30 PET-CT or perhaps in conjunction with PET-CT. Next slide, please. And then in terms of where we are currently right now, we did our Ctep submission. We plan we anticipate getting the Ctep review and approval on hold by end of April. We're planning on a CRB submission at the beginning of May, and review for some possible approval by June, with Ctep final approval hopefully by the middle of June, and distribution of the final approval and setup of the activation dates sometime shortly thereafter in the middle of June, with CTSU regulatory startup by the end of June, and plan for study activation by sometime the last week of June of this year. Next slide, please. I think that's kind of the last one. So I'm happy to take questions at this time.
Great. I just have to say this has been a tremendous amount of work in an amazingly short period of time by Brian Hess and Nash Hussain and a bunch of consultants, both from the Alliance, ECOG, and the BMT CTN. So this has truly been a great collaborative effort, and it's been kind of amazing and fun to watch. I have a couple questions. Number one, the numbers are small, but it looks like the combo might be the best way to go for patients ultimately. And it's nice that patients who get randomized to observation can actually get that combination. So that's an incentive, I think, for all of us to put our patients on. What about the patients that get the single agents? Can they ultimately get the combo?
So as of right now, the way we have it designed right now, but we decided that the crossover, in order to kind of give a more clean analysis, the crossover would be only provided to those patients who were on the observation arm and did not have any intervention. But that would be that if you were on polatuzumab or mosunetuzumab and you switched over to the combo arm, you would have already had exposure to and progressed through one of the two agents in the combination. And so one would question whether this would actually, just give you any kind of actual efficacy or just more toxicity by going to a combination.
I agree, and I think that that's the issue with the combination, because many of these patients will have very soft blood counts. The second thing is, with the FDA approving earlier transplant, are those patients going to be eligible? Those that relapse within 12 months of initial remission or are induction failures, are they allowed to go on this trial?
Yes, so we're actually now that the FDA has approved it in the second line setting. This is something we've been anticipating. We would planning, we would be adjusting the protocol. We have adjusted protocol to allow for patients to be, whether they're getting a second line or third line setting. And that's actually one of the key stratifications that will be a focus of the protocol itself.
So does anybody else have questions in the room or online in the chat? This is again a great trial that even if there's too much toxicity or there's efficacy is not the greatest, we're going to really, in a multi-center randomized trial, evaluate the efficacy of clonoSEQ in determining remission status, even for patients that are in CR, because not all those patients, as we know, are long-term survivors. So we'll be able to further ascertain the value of this as an important sidelight of this trial. So we hope that people are going to participate. People in the room, maybe you can raise your hands. Those that are going to participate in this trial, raise your hands.
I'm hoping there's a lot of people raising their hands.
Yeah, so how about people who are not interested in this and not going to participate? Okay. Again, great work to you and to Brian and getting this up and going. There is going to be a quality of life part of this trial as well. Can you update us on that? Nash?
Sorry, I lost that last one. What was that again? Sorry, my connection kind of fixed up. Could you repeat that again, Dr. Sid, please?
Yeah, so quality of life.
Yeah, so actually, yes, I hadn't put that in yet, but we were actually, as part of making this truly a multidisciplinary effort, beyond more basic science translational studies and looking at the radiological translational a world of studies, we're actually working on a robust quality of life PRO protocol component to this protocol as well, where we will look at the overall quality of life of all the different patients, different age groups, so forth, that are going through CAR T therapy initially, as well as how their quality of life is impacted when they're going through consolidation as well. Because, I think, one thing that we're very much appreciated is that, when you're looking at these, when kind of looking at these different approaches, consolidation and so forth, we need to kind of look at both, getting more insight into the science of how all this is working, what the clinical outcomes are as responses are concerned, but also kind of having a focus on what the quality of life is and how the outcomes and experiences for the patients as well. So.
Okay, anything else? Okay, great, Nash, thank you.
Thank you.
So I'm going to ask gentlemen in the back, are you able to, we have updated slides. So some of you saw I was going in the back of the room. They told us to bring back up my institution, as well as a lot of your institutions, requires encryption, and that created a little bit of a hiccup here. Next is Dr. Kenkre, another trial that's going to be up and going in the lymphoma space in the venue of this committee. Is the phase 3 trial for relapsed refractory classical Hodgkin's lymphoma who are getting traditionally transplanted. Dr. Kenkre from University of Wisconsin hopefully is on the line and will be presenting.
Yeah, I am. Would it be okay if I shared my screen, or will that not work?
We have your slides. So we have the updated slides.
Okay. I'm not able to see them on my view.
You can upload yours on on the Zoom, we'll be
Okay.
able to show them simultaneously here.
Okay, and I just added a couple of background slides. I didn't, initially, I just made a couple of quick slides, but I have a couple background slides in mine as well. So I can share that if that's okay.
Yes, go ahead.
Okay, okay, I'll try to
Sure.
do that.
We're game. We're willing to try just about anything.
Okay. Can everybody see that now? My presentation?
Yes.
Okay, great. I'll try to do a slideshow. I'm not sure if it's showing up as a slideshow or not, but well, thank you for inviting me to present the update on this study. So as Dr. Stiff was saying, this is EA 4211, which will be a phase 3 trial for relapsed refractory classical Hodgkin lymphoma. Just as a little background, frontline therapy for classical Hodgkin lymphoma is curative for many early stage patients and even a majority of advanced stage patients. But unfortunately, as we know, not all are cured. And typically in the second line, we use salvage therapy followed by consolidative high dose chemotherapy and autologous stem cell transplant. And this can offer durable remission and cure for up to 50% or more of patients. And we do know that adding on the consolidative high dose chemo transplant does seem to improve outcomes to just salvage therapy alone. In the last 2-3 years, we have seen data with incorporating checkpoint inhibitor in the second line setting, combining with chemotherapy. And this has shown overall good success and improved outcomes after consolidative transplant. But as of yet, we still do not have a direct comparison in a phase 3 randomized setting of checkpoint inhibitor plus chemotherapy versus chemotherapy alone when being used as the salvage. And so this trial has been designed to really ask that phase 3 randomized question of if we add checkpoint inhibitor to chemotherapy, can we increase the efficacy ultimately of that high dose chemo transplant and the eventual success rate of that entire treatment plan?
Can you hold a second? Because
Yeah.
your slides are not advancing on the Zoom.
Oh, okay. Maybe I'll exit out of the slideshow. Maybe that would help. Are you seeing, which slide are you seeing right now?
Now seeing the formulation of the question.
Okay, okay. And then I'll go to the next one. Are you able to see the schema now?
I think so.
Okay, okay, great. I think I just need to be out of the slideshow then. So this is a very busy slide, but I'll walk you through it. Basically, towards the top left is the actual schema of the study. So this study will be for patients with classical Hodgkin lymphoma who are either primary refractory to their frontline therapy or relapsed after their frontline therapy. They would be eligible and randomized to either get traditional chemotherapy, which would be arm A, versus the traditional chemotherapy plus checkpoint inhibitor, specifically pembrolizumab. As you can see in the box at the bottom right, there are going to be some choices of the chemotherapy backbone. So there will be 3 choices: ICE, GVD, and brentuximab plus bendamustine. If a patient is enrolled to arm A, they would purely get one of those chemotherapy regimens. If they were on arm B, they would get pembrolizumab plus that chemotherapy backbone. And the decision of which chemotherapy backbone will be up to the investigator at the time of patient enrollment, but before randomization. So in other words, if an investigator could choose ICE chemotherapy for their patient, and if they were randomized to arm A, they would get ICE. If they were randomized to arm B, they would get pembrolizumab plus ICE. The idea will be for the patient to get 2 cycles of therapy on whichever arm they are randomized to, and then have a PET scan. And if the PET scan shows a complete remission at that point, or a good partial remission, and I'll talk about that in a minute, they would go on to the standard high dose chemo and transplant. There is the option to get a 3rd cycle to allow time for collection of stem cells and preparation for transplant. If the patient, though, has stable disease or progressive disease after those 2 lines of chemotherapy or pembro chemo, they would come off study and count as an event. I'll take a pause here and explain what we mean by good PR versus not good PR. So when we were first designing this, there was a lot of discussion about whether we should take patients in a partial remission to transplant. Oftentimes, we want to get patients into a complete remission. However, we do think that particularly in the scenario of arm B, where there's checkpoint inhibitor, patients may be able to go into transplant in a PR and then actually convert to a CR. We also know that while even in the standard setting with chemotherapy, even though CR is often better than PR, we do know that from recent data that patients in a PR who go to transplant can still successfully then be converted into a complete remission and have good long-term survival. So ultimately, we decided we would allow patients to go to transplant if they're in a good PR. And in the bottom right box again, we have actually, I removed the definition to make this slide less busy, but what I will say is a good PR is something we were defining as an improvement in the Deauville score and also greater than 50% reduction in the sum of products of the diameters of the target lesions. So in other words, essentially following Lugano criteria, but including an improvement in the the Deauville score as well. So again, going back to the schema, patients in a CR or good PR would go to transplant. If patients were in a PR of any sort and the investigator would like to try to improve upon that response, we will allow a second regimen within the same arm. In other words, if a patient had gotten ICE and had a good PR, but the investigator would like to try to improve upon that, they could give, for example, GBD or BV bendamustine before going to transplant. But ultimately, to go to transplant, a patient must have either a CR or a good PR. After transplant, they would be assessed. If they had not been in a CR, they would be assessed again. If they had been in a good PR but not converted to a CR, that would count as an event, and they would come off of study. To the far right are 2 issues kind of with maintenance or post-transplant therapy that we have decided upon for this study. So per the Athera data, we often administer brentuximab in a particular patient cohort. For this study, we didn't want to make it so strict about whether to follow Athera criteria. Basically, we've decided to allow brentuximab maintenance per the investigator choice, but it should be declared prior to randomization whether or not patients, a particular patient might be getting brentuximab maintenance, so that we can keep track of that, but allow for brentuximab maintenance if the investigator chooses. Similarly, there had been a lot of debate about post-transplant radiation. Many investigators felt that if a patient went into transplant in a good PR but not CR, that they would like to radiate that patient after, even if they converted to a CR. On the other hand, there were some investigators who felt that they would not radiate if a patient converted from a good PR to a CR. So in the end, we were not really able to come to one strategy for management. And so we've decided to allow for post-transplant radiation in that setting of a patient going from a good PR to a CR. However, again, we would like that declared prior to randomization so that we can stratify and keep track of those responses. And so in terms of stratifications on the bottom left, we will be stratifying by the frontline therapy patients receive, by age group, in other words, roughly the pediatric population versus the adult population, and then the intent to use radiation post-transplant. And so the primary endpoint of the study is looking at 2-year event-free survival. we would be assuming an event-free survival of about 65% with the standard arm of chemotherapy followed by transplant. And we predict we can improve upon that by about 15% in the checkpoint inhibitor chemotherapy arm. The events, as I kind of mentioned in that schema, are failure to achieve a good PR or CR to salvage, failure to achieve a CR after transplant, progression of disease at any time, or death. Secondary endpoints that we will look at are 2-year progression-free survival in the transplanted population, the CR rate to salvage therapy alone, the CR rate post-transplant, and then the conversion rate of those good PRs to CR. So there were about 280 or so patients required for the statistical analysis to work out, and then with some extra just kind of planning ahead for potentially losing some patients for various eligibility and whatnot, we have approximately 350 patients planned for this study. So we did receive Ctep approval at the beginning of March. Currently the protocol writing is ongoing, and we plan to be submitting this in hopefully about a month or a little bit more.
Okay, so time for some questions. I was a little bit unsure about the good PR. Does it have to be either decrease of measurements by 50% and or a improvement in the Duvel score?
Yeah,
So,
sorry for not being clear, but both is the answer. We would want both an improvement in the Deauville score as well as a reduction of 50% or more.
so it goes from 4 to 3 or 5 to 4. That's
Right.
sufficient.
That plus the improvement in the sum of the product of diameters.
Okay, and there's certainly intergroup trial looking at PD-1 therapy in frontline therapy. Are those patients going to be eligible for this if they relapse?
Yes, so checkpoint inhibitor in the front line is allowed. It would not preclude eligibility.
And 348 patients is a lot of Hodgkin's patients. So are there concerns that you're going to be able to get sufficient patients, since many patients who are getting novel upfront therapies are doing better than traditionally they would have done in the past?
Yeah, I mean, I think we're still hopeful. I think that if I remember the math, we had said that would be about 16, 17 patients a month. If kind of planning for accruing over about 1.5 years or 2 years, that was when we were talking about the 280. So I think we will need to have it open at several sites, as you point out, as we do better with frontline therapy.
And you're going to submit this to the BMT CTN for endorsement?
Yes. Yep. We have a representative, Dr. Hamadani, too, on the working group.
Brian?
Hi, yeah, Brian, is this on? Brian Till from Seattle here. I wanted to follow up on that. It sounded like you said frontline checkpoint inhibitors are allowed, right? I wanted to just see if you could elaborate on the rationale for that. It seems problematic that if somebody's already failed a checkpoint in the front line, that may kind of skew the results for.
Yeah, I mean, I guess we wanted to allow for for patients on S1826 who are getting potentially nivolumab in the front line. We didn't want to exclude them from being eligible. Like if they were getting that as, instead of ABVD, if they were getting AVD plus nivolumab, we didn't want to exclude them from this study for that.
Will there be a time period before, so if somebody progresses on and the Nivo upfront in that trial, they wouldn't be eligible, or would they be eligible?
Well, I guess if they were, are you saying if they had been treated and
Blew through it.
Progressed,
Yes.
right? I mean, we technically are allowing primary refractory patients, but I would be interested to hear viewpoints on that, whether people think that in the primary refractory setting, whether we should have something in the eligibility about if somebody had just recently received checkpoint inhibitor with their chemotherapy, whether we should make the eligibility so that they would not be eligible. I'd love to hear people's thoughts on that.
Well, I think it would be appropriate to say they would have had to respond to it and then relapsed in probably 6 months. This is things that we've used in the other trial. Brian, would you agree with that? Yeah.
Sorry, I can't hear.
Well, he says, yes, it's better, but he wonders if we should include them at all. So I think it's something that you
Sure.
need to take back to the
Yeah.
protocol committee. And, that's going to be, I think, a very rare occurrence. And as a rare occurrence, I don't think you're going to hurt your trial if you exclude those.
Right. Sure. We can take that back for discussion.
Yes.
Hi, I'm Hildy Dillon. I'm the patient advocate on the lymphoma committee. I have a question about how subjective is a conclusion of a good PR? And so will those PETs be centrally reviewed, or is that going to be up to the study site to interpret?
Yeah, so that's something we've discussed. While we would love to do central review for decision making, because of the often small amount of time that we have to kind of move to transplant, we didn't think that that would really be feasible to do central review as true decision making. We will be retrospectively, we will have central review performed, just not in real time, so that we can then look back at that. We are hopeful, though, that with making the definition of a good PR strict like that, that we will be able to still, capture very accurate responses. Again, an improvement in the Deauville score. So any improvement from a 5 to a 4 or a 4 to a 3, and then reduction of the sum of product of all diameters. So we're hopeful that we spent a lot of time thinking about that, and we're hopeful that that is something that the local investigators can do. And then we'll have a central review after the fact to kind of compare and see if there were differences.
Any other questions?
Put a message in the chat.
Yes. Go ahead.
As opposed to 5 versus 4, we'll see patients that have a PET, perhaps a signal of an SUV of 20. And so pre-randomization, we may say that would be an area of single focus. We're interested in offering post-transplant radiation, but it wouldn't surprise us at the end of chemo and auto transplant if that is still a 6 or a 7. Now, a single focus, now, if we follow those patients, that may still dissipate over time. But those are the patients that typically we will offer radiation to at day 40. When you say not in CR, they're off study. But where is, again, this is going to be a lot of your follow up on the last question, the bias about what is a good PR. A Deauville 4 is maybe not a Deauville 7, but you're on the way down and as a single focus, we would pre-plan radiation. Why would is that patient really going to be off study? You're going to wait till after radiation?
You're asking if they still have a positive PET after transplant, correct?
Yeah, bulky disease patients, we often see that, but we pre-transplant, we can plan radiation. And there's, all of us have experienced patients who, without us biopsying after we planned radiation, we never see disease recur in that setting. There's data from Stanford about using involved field radiation post, auto transplant with, good success.
Yeah, I think that, I understand your point that that patient might, I think what you're saying is that patient might eventually convert to a complete remission and maybe they're improving. I think that the main thing is that we would like to kind of get a sense of which patients are truly being cured by the transplant, ideally. And so, obviously they could go on to get radiation. It's just that we would count them as an event to get a sense that they were not in a remission at the end. I acknowledge that maybe a percentage of those patients might eventually, that might be inflammation and it might improve. But I think just in the spirit of sort of trying to figure out whether this study-directed therapy is getting them into a remission, this was sort of the best way we could figure out to do that, that we would assess them by a day 30 PET and have to count them as an event if they were not in remission.
I do think you'll lose a number of patients effectively that will be cured or will be study patients to follow.
Yeah.
Just to make the comment here.
I think maybe what we should do is also, as best as possible, try to assess what their response is, you know, even 6 months down the line, if possible.
Yeah, I mean, but you're right, the way the scheme is, they're off study. And again, if we're declaring post-radiation is planned up front, it seems like we should allow that to follow through for the efficacy endpoint, not just use the day 30 PET to declare the event. Just a suggestion, talk about it.
Yep. I think part of the issue was that we were interested to see, without radiation, do these patients eventually, you know, go into a remission, even if they don't enter transplant in a remission. But there were definitely investigators not comfortable with omitting the radiation options. So we were trying to figure out a way to allow those investigators who wanted to incorporate radiation to do that, but still allow for those who aren't. So it was definitely kind of a compromise of a lot of different viewpoints.
So I view this as a salvage therapy question, and the next trial hopefully will be a transplant, yes or no. I mean, ultimately that's really the answer, and maybe we can get to your issue ultimately in that trial. But I agree. I think those patients definitely should be followed. We should be watching those patients and maybe document the time to next therapy as one of the endpoints as well.
Sure.
All right, let's keep moving. Thank you. You want to move to the next slide? I think it's Patrick Hagen is next. He's no longer on my computer.
I can't. Can we put the screen back up on the Zoom just because I can't see it? We can't see your presentation there anymore. I can just tell you to advance slides as needed. That works. Excuse me.
You see your slide? I don't think so yet. Hold on, it's coming maybe. I just see IMS Technology Services on my screen. So the next trial is another trial that's coming up hopefully soon. This is a phase 3 randomized trial. DARA VCD induction followed by either transplant or DARA VCD consolidation with the daratumumab maintenance in patients with newly diagnosed AL amyloidosis. I'm not seeing the slides.
All I see is a bunch of Zoom faces, and that's giving me PTSD. So
I'm not even seeing those.
I can try to share my slides real quick. Just
go for it if you have.
Can everybody see that?
If you can put it on presentation mode.
Can you guys see that?
Perfect.
If I
You're hired.
did that did that advance? Did you see when I advanced?
It advanced.
Okay.
Good.
So so this is a study that's been has been in the kind of works for about 1.5 years really at this point, with a lot of collaboration from ECOG, the Alliance, the BMCTN, and a lot of amyloid investigators, really trying to look at answer the question that now with really effective, increasingly effective induction therapies and for systemic light chain amyloidosis, really what is the role of high dose chemotherapy and stem cell transplantation? And so listed here are kind of some of the champions and people we've been working with. This is going to ultimately be a randomized phase 3 study that's going to compare ongoing. So all patients, and I'll go through this in the study schema, will get standard, what we would consider standard induction for systemic light chain amyloidosis, which is DARA CyBORD or DARA VCD. So all patients will get 2 cycles, and then the randomization will be to consolidation. So either to continue for additional cycles, kind of basically on par with what was done in the recently completed Andromeda study, or to go on to high-dose chemotherapy and stem cell transplant. And then all patients will continue with 18 total months of daratumumab maintenance, again, really trying to single out the role of high-dose chemotherapy in these patients. The primary study objective listed here is to compare the major organ deterioration PFS, and this is a relatively new endpoint that was established on the Andromeda study, but this we went back and forth many times, but ultimately with amyloid patients, many going into good remissions and living, really decades sometimes, endpoints such as overall survival or even hematological progression start to be challenging. And for these patients as well, it's not just their light chain reduction and their hematological response that's important, but it's their organ response and lack of progression, particularly cardiac and renal. And those are really the endpoints that make up this composite endpoint of a modified PFS. We're going to be looking at a lot of important secondary endpoints on this study. Quality of life is a huge one for these patients. Transplant is a short-term, certainly quality of life deterioration, but if patients are able to stay in longer-term remissions, we hopefully will be able to detect that. We'll obviously be following for overall survival, cardiac and renal organ responses in particular, but all organ responses. We'll be looking at minimal residual disease, negativity rates in the bone marrow. This is kind of a pretty new area in amyloid. There was actually just a recent publication in American Journal of Hematology that is a little bit enlightening, but still it's in its infancy. And we'll be looking at obviously hematological response and progression, and then ultimately, so treatment-related mortality. So anybody who treats amyloid patients knows that whether they get a transplant or not, they can be a challenging patient population. And whether they get a transplant or not, unfortunately, there's a lot of toxicity due to the organ involvement of the disease. So both on a transplant and a non-transplant treatment approach, we want to know what's the toxicity and, ultimately what patients unfortunately succumb to their therapy. So we can go to the next slide. Oh, that's me. What am I doing? I don't know where I am in this virtual world. Just some brief background. So, while gosh darn it. So while, autologous transplant, the transplant-related mortality was previously thought to be high, and it was back in the 90s and 2000s, really more recently, there's been a lot of data that shows that if done at experienced centers, which you can define as typically doing more than 3 a year, this is now really quite low in the 2 to 5% range. And that's actually on par with what we see with induction therapy in many amyloid patients. So again, when done at a center that has some experience, these can be done safely. We know that induction therapy now, followed by transplant, is increasingly becoming a standard treatment option. Some patients do go straight to transplant, but often patients are getting induction prior to being referred over. And that this combination of good induction therapy, disease reduction, and then auto transplant really leads to the best outcomes. So, and we know that, again, getting induction prior to transplant, as long as the actual melphalan dose, so not being dose reduced on melphalan, are probably the main factors that are predicting outcomes in terms of PSF and survival in our transplant eligible patients. I think one of the big reasons, the fourth bullet point down, why we think this question is really important is that the treatment patterns really around the world are quite different. Here in the US, from our best estimates, maybe about a third of newly diagnosed amyloid patients will undergo an upfront transplant. There's been some large registry data at the UK recently that shows that can be as low as 3.2%. And just across Europe, indeed, transplant rates are much lower than they are in the United States and in Canada, actually, where there's a lot of similar practice patterns. So, and then, recently it was thought to be difficult to enroll patients on these trials, although we've really shown both of the recently completed SWOG trial looking at isatuximab in the relapse setting, as well as the Andromeda study, that I think there's an increasing appetite to enroll AL patients on these studies, and that they're feasible. And really no studies yet have evaluated planned post-therapy, post-transplant therapy for amyloid. So I think it's a unique opportunity. And then important in terms of feasibility, I've listed down here, this is the CIBMTR data. this is pretty stable over the past few years. We're doing right around 300 transplants annually for amyloid a year, and this is even despite, again, newer therapies. So we hope that pattern continues, and ultimately in the past few years in particular, where, again, with daratumumab being introduced in the upfront setting, it seems like those numbers are pretty stable. So in terms of the trial, here are some kind of key inclusion criteria. So patients will need to be eligible both at the time of enrollment as well as following their induction therapy prior to their transplant or no transplant designation per the randomization on the study. A lot of these are pretty well established in amyloid. So again, they have to be eligible to receive a high dose transplant at enrollment. Right now, we have an age cutoff of less than 70, although this has come up by some of our patient advocate groups. But ultimately, right now, that's how the submitted concept is reading. They have to have biopsy-proven disease. They have to have some sort of measurable disease, so either in the serum, the urine, or in the bone marrow. Right now, they have to have a difference in their free light chain of greater than 5. This is also something that's been up for debate because that's going to exclude some patients, although this has generally been the standard and is kind of dictates some of our disease assessments in terms of response to treatment. They have to have a reasonable ECOG less than or equal to 2, and then some of these are amyloid-specific transplant criteria, such as supine systolic blood pressure greater than 90. No, they can't have severe cardiac AL. They have to have adequate, obviously, hematopoietic function. They can have some liver dysfunction, as defined here. Particularly if thought to be related to the amyloid. They have to have a decent creatinine clearance greater than 30, and then no uncontrolled infection or previous therapy for amyloid. And then after they undergo their induction, essentially, none of these criteria are any different. We just need to make sure that the patients are still meeting them because of the known risk, potential toxicity of transplant. The only additional criteria is really they have to be able to actually collect enough stem cells to undergo the transplant, which when we're only collecting for one transplant in AL, typically is not a problem. So here's the treatment schema and kind of the treatment plan. So like I said, so all patients will be enrolled based on the eligibility I just went through. All patients will receive 2 cycles of Dara-CyBorD or Dara-BCD induction. And then if they're still transplant eligible at that point, they're randomized. Patients who are not transplant eligible will still be followed on a registration basis, though. Stem cell collection will not be mandated, but highly encouraged. And this has a lot to do with reimbursements and kind of evolving practice patterns. And right now, the way we have it set up is that randomization will be done following completion of induction therapy. Then they'll be randomized to either, again, 4 additional cycles of the same induction with treatments shown over here on the left, which is standard as per the Andromeda study approach, or to a melphalan-based autologous transplant. And then all patients will go on to 18 months of daratumumab maintenance. So this is actually my last slide. So this is our statistical design. So again, we're looking at one experimental arm, which is designed as high-dose chemotherapy and transplant against Dara-BCD. We're assuming right now, based on what we know of the Andromeda study, to see a modified progression-free survival of about 31 months. Now, again, it's important to keep in mind that this is not just hematological progression. This includes organ progression as well. The way the study is designed, we're going to need 143 participants, so a total of 286 to be actually enrolled and go through treatment. This will give us a 90% power to detect a hazard ratio of 1.61 in favor of the transplant arm, looking to see an improvement in the modified progression-free survival from 31 months up to 50 months in the transplant arm. We have a 2-sided alpha of 0.05 built in, and this is going to be a study that will take about 5 years to accrue, and then ultimately we'll need about 3 years of follow-up. We're anticipating about 10% of patients will be registered but ineligible, and we actually just increased that, even since I put these slides to you, Pat, to 15%. Again, knowing that amyloid is a little bit more of a challenging patient population, and we have to account for both ineligibility due to not being transplant eligible, but there's going to be a very tiny percentage of patients, probably less than 5, but a few that are going to have less than a partial response to induction. And we don't want a patient who hasn't responded to 2 cycles of Dara-BCD just to get 4 more cycles of the same therapy. So, basically in Andromeda, that's less than 5%, but that's going to be an occasional patient. So that's the next bullet point is, the total number of patients that would need to be accrued, accounting for that dropout based on various factors. And then there'll be some important stratifications, or there are some important stratifications built in, including the Mayo stage, the intent to use full dose melphalan versus dose reduced if randomized to transplant, and then again, the depth of response following those 2 cycles of induction. Janssen is supporting the study for study drug patient-related outcome. We're hoping and waiting to receive final word for their support for MRD. I didn't put this in here, but we are doing Mrd assessments post-induction, so those 2 cycles, post-consolidation, and then 1 year post-consolidation. We'd like to do further, but that will depend on funding. The translational kind of work is still in progress, although we plan to do study biospecimen banking at diagnosis, post-consolidation, and a progressive disease. And the quality of life studies are being developed concurrently here, but are still kind of in their infancy. This study was approved by the SWOG Executive Committee, is just submitted actually to Ctep. We will be presenting it in a couple weeks at the TCT meeting to the BMT, CT, and myeloma intergroup, hopefully for formal endorsement. Like I said, they've been involved, but we're hoping for that formal endorsement later this month. And then ultimately to the steering committee, I think our date is May 16th, so 2nd week of May. So this is, I would thank everybody who's helped me on this project, if on this call or not, and the other cooperative groups who have been great to stay involved, because this is a rare disease, so it will need to be an intergroup study. And then I guess my final comment is that actually the Canadian Myeloma Research group will also be formally discussing this study next week, I believe, and they are very engaged and involved and would like to participate again, which will be great for accrual. And I think that was all I had. Yep, that was my last slide. So I'm more than willing to open to questions. This has been a study that's undergone a lot of modifications, and we feel like this is likely the best place to end, but we know there's no perfect study in this disease, and there's more questions than answers, unfortunately, which is why we're doing the study, I suppose.
Okay, we have a question here.
Thank you, Patrick, for the presentation. Aman Godara from University of Utah. Just a couple of questions there. One clause was the orthostatic hypertension in these patients, that the systolic pressure needs to be 90. Would medical management for the blood pressure be allowed to keep it above 90? For an example, could midodrine to maintain pressures up and higher? Would that be allowed for the trial?
Absolutely. Yeah, excellent question. For our discussions, we plan to include that, but we haven't gotten to obviously, we'll just be starting the protocol writing hopefully in the next couple of months. But as our discussions, then yes, as long as with medical management, they would be allowed.
And the next question was that for the stratification for the randomization, could there also be a clause to see how patients who just have renal involvement and don't have cardiac or cardiorenal involvement, could we look at their outcomes in terms of what's the best consolidation strategy for those patients? The reason I bring this up is that, I think when we think about the benefit risk ratio for patients who just have renal involvement and might be pushed into dialysis, if they do have some complications post-transplant, might be a big deterrent factor for these patients. And these are patients generally who do tend to do well. Would there be any considerations like that?
Yeah, it's a good question. We do have, I know statistically we can potentially add additional stratifications. One of the additional potentials that had come up was really organs, a number of organs involved, not renal specific, but it's a good point. I can bring that back to our group. And I agree, I'm more skittish transplanting some of these patients who are on have a creatinine clearance hovering around 30 than I am on dialysis, to be honest. So it's a very good point, and we hadn't specifically addressed that. So it's something I can definitely bring back to the group.
Thank you so much, and hope to see the study open soon and participate as a site. Thank you.
Awesome. Thank you.
Anybody else? Okay, there's nothing in the chat. So if you want to give the screen back and hopefully
Sure.
we can finish up with our last presentations. There we go. So the last half hour, so we're going to talk about MyeloMatch, and Rich Little is online, and hopefully we'll be engaged. We're going to present the first transplant trial of MyeloMatch. For those that don't know, MyeloMatch is NCI funded organized group that is developing a master screening, this reassessment protocol, followed by induction, consolidation, transplant, maintenance trials for high-risk MDS and acute myeloid leukemia. This organization, this group, has been ongoing for several years now, and the first trials, I think, are going to be coming out. And if you attend the leukemia committee meeting, you'll hear about the first SWOG trial, which is one of the earliest trials, induction therapy, that's going to be coming up. Again, there is a group of transplant trials that will be developed, and we're going to present the first one. We've done this before, but it's evolved a little bit. Can I have the next slide? So where we stand on the design of tier 3 trials, and we know that there's some interest, and we haven't really gotten to the point of really starting to design trials. But tier 3 trials are primarily designed for patients who have MRD positive disease remaining after induction, or a tier 2 study, which is what they're called eraser studies, to eliminate MRD positivity in patients in remission. All patients in MyeloMatch will enter the program through a master screening and reassessment protocol, in which molecular typing will be done and available to each site within 72 hours or so of the sample being sent to the MCI. The endpoint of tier 3 trials are the development of MRD negativity after a set time post-transplant. However, for particularly high-risk patients like those with TP53, MLL, even if they're MRD negative, trials can be developed for both MRD and MRD positive and negative patients. The MRD analysis for tier 3 trials will be a flow-based assay, but molecular assays will also be done and correlated to outcome and to the efficacy of a transplant based on the 2 different assays. We cannot transplant patients on MyeloMatch who were initially not screened for MyeloMatch, so patients will need to come into these particular trials through the MyeloMatch front door, which is the screening protocol. The purview of the tier 3 committee is to come up with trials to eliminate MRD or to improve outcome after tier 1-2 trials with a primary endpoint such as MRD negativity after day 100. Still up for discussion, but patients will either continue on a tier 3 protocol beyond day 100 or enter a tier 4 maintenance trial after day 100. Transplant trials can consist of preparative regimen designs, standard or novel preparative regimens with or without targeted agents, or even immunotherapy approaches. They do not have to be limited to specific targets like FLT3 or TP53, and trials for abnormalities that have no targeted therapies available currently can be developed, CD47, for example. Depending on the availability of a tier 2 trial, trials can be developed for patients who are MRD positive after induction that potentially can skip tier 2 trials, but are incorporated as, for example, a bridging study that incorporate both tier 2 endpoints as well as tier 3 endpoints. Next slide. So the first tier 3 trial is a phase 3 Venetoclax trial with an endpoint of event-free survival at 1 year. This has actually just changed within the last week or so. MRD negativity at both day 30 and 100 will be assessed as well. And you'll hear about that in a moment. Once we have the trial design finalized for this trial, we'll be ready to begin to design, I think, other trials. There's already been a proposal for IDH2, and certainly TP53 MLL trials with some of the new novel therapies are certainly on the table. In the meantime, there will also be developed a standard operating procedure protocol for patients on MyeloMatch who are treated with transplant as standard of care that incorporates MRD testing. In other words, we may not have a trial for a particular patient, especially if the Venetoclax trial is completed or what have you. And so there will be a standard operating procedure protocol so that we can follow patients as they go through transplant and evaluate the MRD as it's being assessed by flow and molecular testing to see if we can pick up any clues or hints for patients that might be on local trials or even pharmaceutical trials. So next slide. With this in mind, Matt Riedewald is going to be discussing now it's a phase 2 randomized placebo-controlled trial of Venetoclax. This is based on data from Dana-Farber as obtained by Jacqueline Garcia, and she's also online as well. So Matt, I hope you're there, and we're ready to hear the new updated version of this trial.
I'm here. Thank you, Patrick. So this line study was actually approved back in 2019 as a MRD negative or MRD agnostic study. And then it got kind of, because of MyeloMatch, it's gone through some iterations, and it was going to be an MRD positive study, MRD only for eligibility, and has since, because of possible feasibility, moved back to all comers as a tier 3 study. So again, a double-blind placebo-controlled trial of Venetoclax in combination with reduced intensity conditioning, and then after that, Venetoclax maintenance phase for adults with AML and first CR. Next slide. And so reduced intensity allergenic transplant is relatively ineffective for AML, maybe the best thing we have, especially for older patients, but still the relapse rates are in the 60% range, 2-year disease-free survival of about 42% in the older patients here in the CTN 0502 study, and very similar in the BMT CTN 0901 study in terms of the relapse rates and disease-free survival. Next slide. For MRD positive patients, the picture is even worse, with relapse-free survival probabilities approaching 0 to 10% at 2 years after reduced intensity, well, 0 at 2 years in this one study for reduced intensity, and about 10% with myeloablative conditioning. Next slide. As far as how do we improve reduced intensity and address conditioning allo and address the high relapse rates, eliminating MRD prior to transplant may be one possible avenue, and it's a subject of study in the tier 2 studies. Those patients that go to transplant will be interesting to see how they do. In conditioning, to enhance conditioning with novel agents, we haven't made a lot of progress in conditioning, but with some novel agents can be combined with conditioning and may improve the activity of conditioning. And then after transplant, with either prophylactic treatments like maintenance therapies, cellular therapies, and immunotherapies, or preemptive treatments driven by the persistence or appearance of minimal residual disease after transplant. Next slide. And so the rationale for Venetoclax is that it has single agent activity and heavily pretreated AML with a CR rate of about 20% and anti-leukemic activity of about 40%. It's fairly well tolerated, with myelosuppression being its most significant toxicity in this patient population. Also diarrhea, nausea, fatigue at lower grades. It's an orally bioavailable medication, which is especially helpful after transplant. And Venetoclax at 400 milligrams a day in combination with fludarabine busulfan 2 conditioning and as maintenance has been shown by Jacqueline Garcia and the group at Dana-Farber to be safe and well tolerated. And Venetoclax is predicted to improve MRD clearance and relapse-free survival by increasing the efficacy of conditioning and delaying relapse. Delaying relapse may also increase opportunity for graft versus leukemia effect and possibly increase cure rates. Next slide. I'll let Jacqueline take over here. This is her data.
Thank you so much. So at Dana-Farber, we conducted an IST single site, and this is just the first 22 patients that we published late last year that we previously presented at ASH. What we first did is the first part of this trial that we presented, we added Venetoclax to standard Flubu-2 regimen with the idea of taking the highest risk patients that we want to give a RIC to based on comorbidities or due to age, but recognize that they have the highest rate and chance of relapse. And so we took patients that either had adverse risk AML, MDS or MDS MPN with upwards of 10% blasts, and they had to have intermediate 2 or higher disease or a poor risk mutation as previously validated for those that would otherwise relapse post-transplant. In this clinical trial, we were able to demonstrate that we could add on Venetoclax. We used a dose of 400 milligrams after dose escalation, and we gave it for 7 doses around the time of conditioning. Essentially, patients started treatment on day -8. We in particular did not want to disrupt the schedule for patients and really wanted to use this as a window study with the idea that the addition of Venetoclax would increase the low or apoptotic priming present in any chemo-resistant population that might be remaining post-induction. In this 22 patient cohort, over half the patients came in with P53. And what we were able to demonstrate was not only was there no issues with neutrophil or platelet engraftment, no increase in acute or chronic GVHD, but we had an overall survival of 67% by 1 year. What we have here is demonstration of genetic MRD assessment performed by Coleman Lindsley in his lab, taking a look at deep MRD responses using duplex sequencing from the time of screening to day 28 when available. This was also occurring during the pandemic, so we lost some samples along the way. Day 100, 6 months, 1 year, or relapse when if that occurred. What we were able to demonstrate, the other groups have similarly demonstrated, is that there are certainly patients that have persistent disease based on MRD status by day 28, day 100, that represents a vulnerable therapeutic window. And those represent the patients that are highest chance of relapse. Next slide. So we've gone on to amend this protocol and it's still ongoing. This occurred in the setting of the pandemic plus the approval of Inqovi. What we did was we added parts 2 and 3, where we assumed that the Venetoclax plus conditioning with Flubu-2 was safe, well tolerated, which we confirmed in part 1, and then we added on maintenance that was planned in parts 2 and 3. Part 2 is the traditional aza-ven at reduced doses, and traditional meaning using standard IV doses that were mirroring the maintenance IV azacitidine approach. And part 3 will be using Inqovi at lower doses with Venetoclax since the oral drug became approved. We're currently enrolling. What I could tell you so far is that we have not yet seen any DLTs with use of maintenance. We've been able to screen patients after day 28 and get them started mostly before day 90. And it's been well tolerated so far on a 42 or 28-day schedule. And we hope to present that data later this year with more long-term follow-up. Next slide.
And so the study design I've already talked about, the randomized phase 2, myelomatched baskets are older AML principally, younger AML for the rare younger AML patient who may get reduced intensity conditioning, and then an MDS exploratory cohort. This would be a tier 3 myelomatched study that would be alliance-led intergroup study, hopefully with the endorsement of BMT CTN. And the rationale for this design is that a blinded placebo-controlled study is more likely to keep patients on study and prevent alternative maintenance strategies by providers, especially if they have MRD data locally. Next slide. And so the hypothesis is that addition of Venetoclax reduced intensity conditioning followed by maintenance Venetoclax after transplant will improve 12-month event-free survival by 20%. Relative to placebo. That should say from 15% I'm sorry, that's right, from 15% to 35%. The addition of Venetoclax to reduced intensity conditioning for allogeneic transplant for MRD positive AML will increase MRD clearance rate by 15% relative to placebo. And then Venetoclax maintenance will reduce disease recurrence or progression by day plus 100 compared to placebo. Going back to the event-free survival, that is incorrect. It's supposed to be 40% to 60%. Next slide. And so this is some formatting issues, but this is the schema. eligible patients, adults with AML and CR1, in an MDS exploratory cohort. Primary objective, 12-month event-free survival, with events defined in the yellow box there as MRD recurrence, MRD progression, progression in case of MDS, relapse or death from any cause. Patients will be randomized in a blinded fashion, likely stratified for MRD status at randomization, as well as conditioning and cytogenetic risk. The experimental conditioning is fludarabine and busulfan 2 with venetoclax, or venetoclax, fludarabine and melphalan, versus conditioning B, which are the same regimens, but with placebo. The venetoclax is stopped at day -2, last dose on day -2 of conditioning to allow washout prior to stem cell infusion. Patients are then allowed to recover from their transplant, subsequently get a bone marrow at day +30, and go through a second randomization to either maintenance venetoclax or maintenance placebo. And the reason for the second randomization is to be able to tease out the differences between the activity of venetoclax and conditioning versus the activity of venetoclax as maintenance. As far as disease assessment time points, day 30, of course, prior to randomization, then day 100, 6 months and 12 months. Any events during this time, especially including MRD recurrence or MRD progression, patients will come off study treatment. And for the MRD recurrence and MRD progression, they could potentially go on to the tier 4 myelomatch studies. Those are the maintenance or preemptive therapy studies. Back to objectives, key secondary objectives are MRD clearance at day 30, day 100 event-free survival, and tolerability. Next slide. This is just a quick look at where these MRD positive, persistently positive recurrent patients could go, and there's a number of potential tier 4 studies that might make sense for patients. Next slide. And so the primary objective, this is new since, well, this is kind of going back to the older iteration of this study, but we've moved away from MRD positivity because that would, we think that would limit accrual unacceptably. So 12-month event-free survival with the event defined as before for the entire regimen, which would be the A randomization and the A1 randomization compared to the B randomization and then the B2 randomization. And then key secondary endpoints with the conditioning are MRD conversion to negative at day +30. That's A versus B with a null hypothesis of 70% clearance and an alternative 85% or 90%. Maintenance questions, looking at the arms that are randomized to venetoclax versus placebo maintenance, and then the regimen as well at day 140. Next slide. Key eligibility I've already touched on, so we can go to the next slide. And so the statistics, this is preliminary, quick statistics. And so event-free survival 12 months, if we are fairly loose with our alpha and choose a power of 80% or 0.8, we would need about 106 patients or 53 per arm. And when I say arm, that's the arm A plus A1, the all venetoclax regimen versus the all placebo regimen. So the study as a whole then would need about 212 patients. And that would give a power of 0.8 to detect a 20% difference in 12-month event-free survival using a one-sided alpha of 0.1. The key secondary endpoints would be MRD conversion with for this statistical analysis, a conversion rate of 70% to 90%. This would require 70 patients, which we would need to mandate having 35 or total of 70 MRD positive patients going into transplant, and to have a 80% power to predict this 20% improvement in MRD conversion rate with a one-sided alpha of 0.1. we're going to have a meeting with Boris Friedland and Jennifer Rademacher, to further work on the statistical design. It's hard to see a design that's not 200 patients, though, for the primary endpoint. And then I think it's the last slide. Competing trials is AbbVie-VLT, which is the phase 3 venetoclax azacitidine versus azacitidine maintenance after allotransplant for AML. That's myeloablative. And there is one more slide. And so the suitability for MyeloMatch is that this is targeted therapy, but across AML mutational subtypes, which will improve accrual and feasibility. The phase 1 data is complete. We have an important clinical endpoint of event-free survival as the primary endpoint. Mrd assessment is integral, both for patient accrual as well as stratification and randomization. And venetoclax is attractive in combination with other targeted agents. So as we move forward, thinking about potential combination maintenance post-allotransplant, venetoclax is attractive as that. As an oral agent that can be combined with other agents and has shown synergy with such agents in vitro. And assessments and endpoints allow for early transition of MRD progressive or MRD recurring patients to other targeted therapy protocols as available through MyeloMatch. It's also ready to go. So with that, we can take questions.
Before we do, I'd like to open it to Rich Little for any comments on MyeloMatch in general, MyeloMatch transplant trials, or this particular trial. Rich, not putting you on the spot.
Yeah, you are. Hi, everybody. It's Rich Little. A lot of work has gone into this, and I think adapting it for MyeloMatch, I think that Matt and the team have done a great job, and it'll go back to the combined chairs of MyeloMatch to look at this redesign again, and hopefully we'll be able to incorporate it soon. So currently the MyeloMatch is hoped to launch sometime around mid-year this year, end of the year this year, and there's a master screening and reassessment protocol and 3 treatment protocols in the young adult AML basket that are currently under review, and that have approval from the drug companies as well as Ctep, but are just being refined so that the laboratory component and the clinical components all line up. And then we'll go to the FDA with the whole effort. So that's a very brief update for MyeloMatch, and hopefully we'll have a number of transplant protocols and cellular therapy incorporated eventually. And I think this is a good start.
Okay, questions. There's one from Rich Mayers. The analysis of BMT CTN 901 revealed that not all mutations have the same malignant potential. Will this differential impact of MRD mutations be taken into account?
So not prospectively, I think, but it's definitely a exploratory, will be an exploratory objective of the study. The main MRD analysis is by flow, and then the kind of secondary MRD analysis will be through the molecular. So hopefully we'll have such detailed information through MyeloMatch. We'll actually hopefully be able to comment more on the different mutations and how they impact outcomes, and what their role may be in MRD, specifically in the setting of this regimen.
And the other major one that people keep bringing up is based on 0901, showing benefit to myeloablative regimens. Do you think that will have an impact on this trial, or where do you think that should fit in?
Up to a certain age is the answer. There's a benefit to the myeloablation. The question is, when you this is going to be primarily an older patient study. We also have melphalan in there, And, you know, if that becomes, we settled on melphalan 100 based on the MD Anderson data, but we may be able to open that up to melphalan 100 and 140, in which case you have a you know, something that, although not, is fairly myeloablative, almost full intensity in terms of if treating physicians want that kind of intensity for their older patients.
One thing I like about this trial is that there's going to be some exploratory new MRD measurements using double strand analyses, and we'll be able to compare the relative value of flow MRD for AML versus some of these newer assays, ultimately retrospectively as well. And indeed, somebody might be flow negative, but MRD positive by some of these newer, more sensitive assays at 1 in 10 to the 6. That might indicate a higher propensity for relapse if given placebo as well. So would encourage everybody to begin to think about enrolling on this. And as Rich Little said, the screening protocol hopefully will be up and going within the next 3 or 4 months, or certainly by the time of the next meeting. And we should be ready to go. I think SWOG is going to have one of the first induction trials. So looking forward to everybody participating. These trials are not designed just to be done at academic centers, but also community centers where AML patients are treated. The analyses are going to be, again, for MRD done centrally, not locally. Any other questions that people have? Yes.
Yeah, hi, this is Hildy Dillon again. I just have a question of how is MyeloMatch handling consent? Is the patient presented with a consent at each tier, or are they consented for every, anticipating what their next step would be if they've reached certain milestones?
Rich, you want to tackle that one?
They're consented. So they're consented initially for the master screening and reassessment protocol. And then there is molecular work that's done, and it's put through an algorithm for protocol assignment. And when they're assigned to a particular protocol, that they're then consented for that specific treatment protocol. At the end of that study, they're reanalyzed through the master screening and reassessment protocol and then reassigned. And when they get that assignment, they're then reconsented for that specific protocol.
Anything else? Well, this has been a real experience. We're a little bit over time, but we did get started late and we had a few glitches in the middle. So I really, really appreciate all of the speakers, especially the technical expertise in the back of the room. Thank you, sir. And the encrypted devices. And I hope the next meeting, which will be in Chicago, so I won't have to drive very far, but that everybody will be able to attend in person so that we can actually have more of an in-person discussion. And hopefully by then, the first MyeloMatch studies will be up and going, and we can talk about how things are going. So again, thanks to all the presenters and thanks to all of you for coming online and in person to this meeting. Enjoy the rest of the meeting. Thank you.
Yeah, it's a great portfolio of studies we heard about today.